Everyone, greetings from Durham, North Carolina. I'd like to welcome you all to this live webinar organized by the American Society of Echocardiography. This is a follow-up to the first webinar on March 19th to address many of the questions that came up at that time. This particular time was chosen to allow those who could not join us last time, especially our colleagues in Europe through South Asia, to participate. At the outset, I'd like to thank our fearless sonographers and echocardiographers who are working in institutions throughout the world at the front lines. I'm grateful and inspired by your work. I'm Madhav Swaminathan, current ASE president. I'm joined by Dr. Hung, who is the ASE president-elect, and by Drs. Kirkpatrick, Mitchell, Kort, Taub, and Ms. McClanahan and Hua from Massachusetts General Hospital, and Dr. Pottinger, who is an infectious disease expert from the University of Washington in Seattle. At the back also joining me are, and who are making sure that everything is working as planned, are ASE staff, Christina LaFuria and Liz Lane. So please use the question and answer tab in Zoom to ask any questions. We'll try and get through as many as possible. And just as a reminder, this webinar is being recorded and will be made available on our YouTube channel very soon. And as you log off, you'll be redirected to our COVID resources page to help you navigate COVID resources at this time. So let's go ahead and get started. We'd like to thank our sponsors, GE, Hitachi, and Philips for helping us with this webinar. As an outline, we'll provide an update since the webinar on March 19th, which was held at that time at 7 p.m. and Dr. Kirkpatrick will take us through that. We'll also then break and discuss how hospitals are coping with echo scheduling, PPE policies, and provider safety. It's sort of an update since the last webinar from a few institutions represented by the participants here. And then we'll finish off with a quick Q&A with the panel. Jim, would you like to take that from here?
Absolutely. Thanks very much, Madhav, and greetings to everyone from Seattle. We just want to quickly go through some of the things that are included in the ASE document on the subject and that were presented to some extent in the last webinar. This is sort of the main graphic that walks people through decisions in regards to echocardiography in this time of COVID. The first question, obviously, is whether an echo is indicated. And we use the AUC, the appropriate use criteria, to help determine this, but also the idea that some echoes can actually be postponed and deferred till a later date because they're not going to give actionable information that one needs right now and could be safely done later. However, if that is not the case and an echo needs to be done, then we need to figure out what the patient's COVID status is. And if the patient is positive or it's suspected that the patient is positive, and certainly someone waiting for a test coming back would fit into this category, then we have to consider where the patient is and what sort of test is being requested. If it's a transthoracic or a stress test, then we look to see if we're performing this potentially in the echo lab, portable on the wards, the cath EP lab, or in the emergency department. In those cases, then we would recommend what's called droplet precautions, and we will go over what that means. If, however, it's in the ICU, the operating room, invasive or non-invasive ventilation is being administered to the patient, in these settings, we would recommend airborne precautions, and we will talk about that as well. For all transesophageal echocardiograms that are on people who are are COVID positive or suspected or waiting for their test to come back, we would recommend airborne precautions. This is controversial, but we have some good reasons for making this recommendation. In addition, we have to think about some special considerations, and that is specifically the type of protocols that we're using. We likely should not be doing comprehensive echocardiography on patients who are positive and prolonging exposure time. Instead, we should be thinking about using POCUS if there are trained operators and equipment for that, and doing focused imaging. In addition, other aspects of protection, we should consider, if we can, the issues of staff, and certainly essential personnel, not including students. We really shouldn't have learners spending time and prolonging these exams on COVID patients. In addition, we should think about limiting exposure to staff members who are at relatively high risk. If patients are negative for COVID, and some people would include very low risk patients in certain areas there, then of course we do standard precautions. We at the University of Washington do droplet precautions for all transesophageal echoes. We normally do that, but we're particularly more adherent to that in these days. This is a moving target. There are changes, as you're aware of, all the time. And if we can move on to the next slide, we can define some of what we mean by the different types of precaution. Hand washing, we hopefully have all become very, very familiar with, and this remains a cornerstone. Even as we talk about all the different types of personal protective equipment, we must not ignore the importance of hand washing across the board in every type of risk category. Gloves or even double gloving is certainly appropriate. Isolation gowns for droplet and airborne precautions. And then the issue of masks is the one that's a bit more controversial. Certainly using a standard surgical mask in standard operating procedure is probably somewhat wise these days, and certainly is indicated for special droplet procedures. If there was widespread availability of N95 or N99 masks, then one could consider, as per the CDC, that special droplet precautions as well as airborne precautions should include these. However, we are in a time when these masks are not widely available. We have to conserve them. We have to be careful about the use of our resources. And really, if you think about it, while we would love to protect ourselves and our patients, the reality is we live in a larger environment. We have to think about the fact that if we use up a mask that is then not being used in a very high-risk situation, we're putting someone else at risk. So we really have to view this to some extent through our community lens. Face shields are very important for droplet and airborne, and in some cases, in the lack of face shields, they're going to goggles. PAPR systems, which you can look up online if you haven't seen one, are appropriate, particularly in airborne situations. If there were a lot of them available, perhaps special droplet. Surgical caps and shoe covers are recommended in some locations. And again, just to emphasize that patient location may determine your level of protection, please check your local protocols for more information. Next slide. This is from the CDC. We at the University of Washington, many other places, have what we call donnicers and doffacers, people who watch us put on or don our personal protective equipment, and people who watch us take it off. These trained individuals are there to remind us how to do it properly, because of course in the setting it's very easy to potentially forget and miss something. This is quite an involved process. It is not sort of something that we are used to doing all the time. I suspect we will all get much better at this as we go forward. Next slide. This, of course, is how to remove things, perhaps even more important than putting them on in terms of infection spread. But obviously, you want to cover up all the parts that need to be covered up and make sure that you are not going to be subject to either the droplets or the aerosolized particles that could infect you. Next slide. And of course, we already mentioned this, but consider limiting the roles of staff. I can tell you that as we have limited our outpatient level, we have quite a few people available for other things, and we are able to make accommodations in these cases of the immunocompromised, older individuals, people with chronic diseases, and perhaps pregnant staff members as well. And then obviously, we don't want to perform measurements while we're in the room. Anything that does not have to be done in the room should not be done in the room. Wait until you're outside in the hallway or potentially even back on a different workstation to make measurements on your echocardiograms, and just make common sense essentially in doing this. Next slide. Cleaning and disinfecting equipment is a major issue, and manufacturers have different recommendations. There have been some changes, and so you have to keep up with the manufacturing recommendations. But in general, once is not enough. And the idea there is to clean inside the room while you're in your full protective equipment. The machine then must be moved out of the room and cleaned again while someone is wearing protective equipment. In our case, we usually have the donicer, dofficer do this, but some cases you might have to have someone come out of the room after removing the personal protective equipment, put something else on, and then clean it again. Importantly, as with cleaning everything these days, we have to pay attention to the wet time. Just wiping down the equipment and moving on is not enough. You have to wait to make sure and allow it to be wet for a certain amount of time for optimal effect. Next slide. Please don't forget that it's not just the machines. Your workrooms, your reading rooms are important. The keyboards, the mouse, the desk, the chair, the phones, and the doorknobs are things that should be wiped down as well. And of course, you want to reduce traffic in line with good social distancing practices. In some cases, the Echo Lab is kind of the epicenter or the heart of cardiology. This probably shouldn't be the case right now. You may have to actually do a lot of remote consultation, going through studies online with people and giving that information that normally people would come down and stand over your shoulder looking at the images. This is not the time for that. Next slide.
Okay, thank you so much, Jim, but I'm going to stick with you because what we'll be doing right now is talking about how hospitals are coping, sort of getting an update from the major centers. And so I'll hand it to you, Jim, and after you're done, I'd appreciate a word from Dr. Hung in Mass General Hospital, and then Smadar Kort from Stony Brook, and then Cynthia Taub from the hotspot of Montefiore. So Jim.
Absolutely, thanks so much. So in Seattle, we are in, at least right now, a somewhat fortunate position. We are not overwhelmed. The projections are that while we are right now experiencing sort of a leveling off of new cases and deaths, that our peak has not been reached. We're expecting that in 1 to 2 weeks. And Paul can certainly correct me if I say anything amiss, and he probably has more up-to-date information on that. But what that is allowing us to do is lots of planning. So we have had lots of ability, and in many ways, this is probably due to the fact that we were one of the earliest sites. We were able to institute things early on, think about issues, and really plan. And then sort of the Seattleites' natural social distancing that occurs during the winter and bad weather has no doubt helped us a great deal. So we have been able to think about many different things, not only a lot of the issues that I already talked about in terms of personal protective equipment and machines and staffing and everything else, but we also have been able to institute the use of POCUS. And in particular, we are training and forming lots of relationships with POCUS users in the hospital, the emergency department, the ICU, and the hospitalist service. We are providing training for them by use of a simulator developed by Florence Sheehan, and they are going to be ready. We've also been able to get a number of small devices that they can use, and we have found ways to connect these devices to our reading software, our PACS system, so that we'll be able to look at these images that have been generated, plan out our echocardiograms, and hopefully reduce exposure over time. So I think this is actually going to be very important. We are in a different situation. The projections also say that we are very unlikely to not have enough ICU beds, even if we have a kind of a maximal situation. But again, this has allowed us to do a lot of good planning and really prepare for any surge that is coming down our way.
Excellent. Thank you so much, Jim. I'd like to move this to Dr. Judy Hung from Mass General for her comments.
Sure. Thanks, Madhav. So I pretty much, we're in a situation similar to Seattle. We are on the rise, and our projected peak is in 1 or 2 weeks or so. And I would essentially, we've been doing similar, processes that Jim is doing in Seattle. I will say in regard to the echo scheduling, we've had to essentially cancel or postpone the vast majority of our outpatient echoes, including TEE and stress echoes. And for the inpatients, we are, being stringent about the indication for the echo test and whether it's going to change management for that. For the PPE policies, we certainly have changed our protocols and increased our PPE pretty much along the guidelines as recommended by the ASE.
Thank you so much, Judy. I want to just proceed because I know we're going to lose Dr. Pottinger very shortly. So I want to get his take on things, but I want to go to Dr. Cynthia Taub. I'm sorry, Smadar, we'll come back to you for Stony Brook. But Dr. Taub, do you want to say a few words about an update from Montefiore in New York?
Certainly, we are in the epicenter, and our volume has been increasing exponentially in terms of COVID patient being admitted to the hospital. As an echo lab, operationally, we've been constantly changing, struggling how to accommodate the operations. Initially, we were performing triaged echocardiograms, patients who can stay in the lab, perform echoes in the lab are supposed to be COVID-free, and a group of sonographers are doing portable echoes on the floor. And the last week, we were unable to do so. All the echoes are performed portably to the patient's floor. Important questions related to how to protect our sonographers, how to make full use of our N95 mask. Certainly we're reusing them, and the key consideration is how to maintain N95's fit and function when used continuously or intermittently. Our practice is to cover the N95 mask with a surgical mask with a face shield. And importantly, when you take off the surgical mask, you need to be very gentle, avoid touching your face. Another thing I would like to highlight, some questions about utilizing your trainees to perform echoes. Certainly, the number one philosophy at Montefiore is do not ask our fellows to go to places where attendings are afraid to go to. Always protect your trainee. But on the other hand, the fellows are going into COVID patients' room to evaluate these patients anyway. They're in the best position to quickly scan patients. So you should plan ahead of time. Eisenhower said planning is nothing. Plans are nothing. We always have plans, but planning is everything. Have your fellows learn to use POCUS and set up systems to store images for interpretation. And we've connected all our echo attendings with our critical care POCUS studies on QPath, a storage cloud for our critical care colleagues. So previously, Echo Lab and critical care works in silo, but now this crisis united us and we're working hand in hand.
Yeah, thank you so much, Cynthia. We'll move straight to the question and answer.
Oh, Madhav, you're muted. I'm so sorry. Christina, can you send him a message? I think he's hit the space bar.
Sorry, my fault. So a lot of questions coming in on aerosolization, and one of the things I'd like to ask Dr. Pottinger is, there are questions on should the filters be cleaned after each use, and do machine fans, which are on our echo machines, and there are so many questions coming on that, do they amplify the aerosolization that's going on? And is there any take from infectious disease experts on this?
Thank you so much. Oh, I really appreciate it. First of all, I appreciate the invitation. Second of all, I am so impressed with what ASE has done. I am not aware of another society that I have come across in this whole epidemic that is so organized this way, with a website that is so clear and easy to use. So that's kudos to all of you for doing this. It makes my job so much easier that you have one national repository for information. So I do recommend that everyone please do, very familiar with the ASE website. It's superb. These particular questions that you're looking at, some of them are addressed very explicitly in those guidance documents on the website. Some are not, and in the case of one that's not, does relate to the fans, the way that the machine should be processed. Let me answer to the best of my ability. What you heard from Dr. Kirkpatrick is exactly correct. By far, the biggest issue that comes up in our practice with regard to the machine itself is that the surface must be kept clean. And I loved what he said about cleaning and wiping down with an EPA-approved product, usually containing alcohol, although a quaternary ammonium compound or a combination is perfectly fine. In other words, your standard wipe that you use in your clinical setting, very virucidal, very effective. For the surface, the knurled knobs, the buttons, the screen, anything that has been touched, that is by far the biggest priority. The issue about the inner workings, the guts of the instrument, you need a fan to blow because that keeps the GPU cool. We can't turn that off. Please do not block the ingress or egress of that airflow. So there is a filter that's in there, absolutely. What we do in our process here, we are sticking to our standard process for processing that machine. We are not currently going after the inner guts of the machine in a more aggressive way. This has been an opportunity for us to ensure that all the instruments are getting at least what the manufacturer recommends. This is always something that comes up with all epidemics. Make sure you do at least what the manufacturer proposes that we do. Does that fan blowing so hard increase the risk of aerosolization? Let me be clear. For patients getting a transesophageal echo, we think that they should be handled in airborne precautions, exactly as Dr. Kirkpatrick said. That could be a PAPR device, it could be an N95 mask, something to get those finer microscopic particles away from the body. They could, in theory, yes, be blown into that, into the guts of the machine and then out into the room again. It is fine because you're now in airborne precautions. In a patient who is getting a transthoracic echo, a surface echo, we do not think that those patients are coughing out the microscopically small particles, which might, in theory, get drawn into the machine and then back out into the room. So for, just to be clear, for transesophageal echo, you're in airborne precautions. And that's great, you're protected. No need to go after the machine, inner guts, or the filter in that situation. For a transthoracic echo, you're in droplet precautions with a simple surgical face mask, eye protection, gown, and gloves. And that should not get drawn into the guts of the machine in that situation. So is TE considered aerosol generating procedure? Yes, it is. We think that that is a rare occurrence, but it is a theoretical issue, especially if, God help us, if the probe goes down into the trachea, that will cause basically an intubation of the trachea. You're not supposed to do that, but if that does happen, it's a concern. What about a patient who is intentionally intubated, undergoing endotracheal intubation? They're coming out of the ICU, they're in the ICU, and that's where you are seeing them. Those patients, we do handle in airborne precautions as well. I want to be very clear. We like that when it comes to the reducing the risk of aerosol generating procedures. When the patient is intubated, they're actually not going to put out fine particles into the room. There's a HEPA filter, in fact, on the ventilator itself, as you know. The only reason we do this is in case they pop off. And this happens on average once a day for most patients who are ventilated. If they pop off and that tube all of a sudden becomes disconnected from the circuit, then we think those microscopically fine particles are a risk. So that's why we propose that anybody who's got endotracheal intubation should be handled in airborne precautions, just in case they become disconnected. Should the room be shut down after use? Thank you for that as well. For patients who are being handled under TEE, that is an airborne generating procedure. And therefore, yes, we do consider that the atmosphere within the air of that room is contaminated with viral particles for at least a short time after the procedure. How short a time are we talking about? Depends on the air exchanges per hour. Or air changes per hour, you'll see in the literature, the ACH of your room. Working in your institution, you should be able to go to your environmental safety officer and the infection control team. They should be able to tell you how air is being handled in your center. In my hospital, there's tremendous variability. Our average is about 6 air changes per hour, although in our operating rooms, it is more than 12. In a negative pressure room, where many of these patients will be, it is also north of 10 per hour. So you need to know that policy and protocol that should be available to you. In my hospital, the answer is yes, we would keep that room closed for 1 hour. Why 1 hour? Because at our lowest air changes per hour, which happens to be 6, we know that after 45 minutes, 99% of the air is gone. And we add an extra 15 minutes because it's a round number. Please check with your institutional safety officers for what their procedures are with you.
Okay, perfect. Thank you, Paul. One of the other things that came through, and let me just move to the next slide, is do TEE probes need to be cleaned differently? And does UV light work on the echo machine? And these were questions that came up on the last webinar. One of the things I'd just like to add before you go on to answer this one is that we did reach out to some of our manufacturers regarding the filter cleaning process, and they indicated that the filter is certified to filter out particles, but not for droplets or airborne precautions. So they didn't make any recommendations specifically for COVID, but directed us to the CDC site, which does not either give any sort of guidance on what to do with the filters. But I do know that several institutions, what they've adopted is having a separate machine specifically for TE purposes, or where you're going to go into airborne rooms and sort of reserve that machine for that purpose alone.
I think that's a rational step, although it is, you will not find official guidance on it. It does make sense. Not every center is going to be able, I suppose, to quarantine one machine away. Our approach here is to say that when that machine leaves the room and it has been cleaned, we'll talk about that in a moment, that it is good to go. We really do feel that the chance of that machine then becoming a source of infection is just really, truly extraordinarily small. And to my knowledge, indeed, that has never been reported. Do the probes need to be cleaned differently? No, the probe must be cleaned. You know this from every single patient that you see, whether it's Staph aureus you're worried about or herpes or whatever, the probe must be clean. And the good news, there's very little good news about COVID-19, but one of the good news is it is an RNA virus. It is a coronavirus. We do have long experience decontaminating that from SARS-1 and before 20 years ago. This virus is easy to kill. It is not a hardy virus, not like norovirus, not like C. diff spores. Any EPA-approved standard process that you would normally do for that probe should be very, very sufficient to decontaminate it from coronavirus. As always, what a nice opportunity for us to ensure that our process is rigorous, that we are doing it properly, that anyone who is not sure how to do it is observed by a trained person to make sure that they're doing it per manufacturer's guidance. If in doubt, wipe it down. If in doubt, wipe it down again. This is the bottom line, but we do think that it can indeed be done by standard, rigorous, meticulous process. Does UV light work on the echo machine? UV light, what an interesting technology. UVC, ultraviolet light, yes, it does seem to inactivate this virus. Like I just said, it is very much a killable virus. The issue of UVC relates to the dose and the technique and the angle at which the radiation hits a particular surface. A knurled knob on a machine might be more difficult to treat than the smooth surface of that very same machine a few centimeters away. So the answer is yes, it does seem to work. We are using this technology as an additional adjunctive terminal clean for patients who've been staying in COVID-19 precautions. We have the Xenex platform. You may have other UVC generating platforms at your hospital, or you may not. We do not rely on UVC to clean these rooms, period. Standard cleaning precautions are absolutely the way we go. We are fortunate to have a few of these robots that will roll into into a room after a patient has left, but we do not rely on that. Frankly, I like that better for gram-negative rods, multi-drug resistant Pseudomonas, and other things. For this virus, rigorous cleaning by itself should be okay.
Okay, Jim, do you want to answer some of these as to what's going on, or Dr. Kort? In terms of some of the cleaning processes?
Yeah, basically everything that Paul said is what we are doing. In terms of some of the questions about other sort of aspects, there have been other things that have been proposed, barriers putting up between the patient and the sonographer, covering machines and that sort of thing. And I think it might be good to hear from some of our sonographers in terms of some of those aspects as well.
Yeah, I'd like to move on to perhaps Lanqi and Carlene, if they want to opine on this.
Thank you for letting us, inviting us here. So yes, just like speaker said that the cleaning the machine is basically very similar as you cleaning other machines. Have to be mindful that when you're doing this, you have to really clean the machine from top to bottom. Don't forget about surface of the machine, the screen, the touch screen, the keyboard and cord, and of course the probe and plus EKG cables. I think the most important things on this, and now we like to highlight it, is that remind all the sonographers that when you go into the ICU unit, how do you have this PPEs on you, and with all the PPEs on, what's the right steps sequence to do this when you are cleaning the machine. So in our right now we recommend people we need to to, we have the mask on, goggles on, facials, cap, gloves, and gowns on. We normally try to, we should move the machine to the ND room if the patient has the ND room. If not, we move the machine outside, right outside the door. And then we remove the gowns and gloves out and turn it into the patient's room, and then cascade your hand and then change a new gloves. You should keep your mask on, your goggles on, your cap on, your spine. And so you clean your machine with that. After you're done with the cleaning, and so you can take the gloves off. The reason I said that this is very important, just as important as you take off your PPEs after you get out from the room. So because it's easy to contaminate to your machine. So after you clean up your machine, you take the gloves off, cascade your hand, and now you can take your PPEs off from your and then follow the steps that CDC recommended. So also there are some of the sonographers that like to do is that we normally have this machine covers on top of the machine. So some of the sonographers like to do is with the covers on, bring the machine into the room with the covers on. So basically do this echo with the covers. So when you get done, when you're done with the echoes, you can just take the cover off, just like you take off your PPEs and throw into the patient's room and bring the machine outside the patient's room. But you still, even though with the covers on, you still need to clean your machine also, just like you normally do, including the surface of the machine and the probes, everything else as well. In our hospital, we do provide another covers, like we want people to cover use a new clean plastic covers, cover your machine after you're done with your cleaning. So before you bring the machine back, that's how we are doing this. It's just have to be mindful that, the machine cleaning is very, very important.
Thank you, Lanqi. The questions are coming fast and furious on some of these issues as to how do we treat patients who are not known COVID, and shouldn't we be using N95 considering that we have fresh evidence of the airborne nature of this? Shouldn't we be using or suggesting N95s for all cases until they are proven negative? And Dr. Kort, do you want to take this question?
So I wanted to mention that Stony Brook, which is the hospital where I work, and you can see the beautiful Long Island shore right behind me, has been quite innovative, and we really have to think outside the box with such short supply of PPEs. What we've been doing is actually use 3D printers to print face shields. The chemistry department is producing gallons of sanitizers for us, and we now decontaminate the N95 masks that were used during aerosol generating procedures, such as TE, bronchoscopy, etc. So those can now be reused. We typically reuse N95 that are used for any other procedure, which is not aerosol generating. We do use a surgical mask on it to protect the N95, so it can be reused over and over again. In terms of non-COVID patients, at this point, the vast majority of patients that we see at Stony Brook are COVID patients. And some of them are still what we call PY, under investigation, but like I said, the vast majority are either confirmed or PY patients. So for the very few patients that are not, it really depends where they are. If in your institution you have mixed of COVID and non-COVID patients, you kind of need to be protected of yourself whenever you are in a hallway, because there could be some droplets around. So I would say that it really depends on where you are, how many COVID patients you have, and whether or not you can confine those patients to a different area. Otherwise, you should really suspect that every patient in your hospital is a COVID patient.
Thank you so much. Dr. Hung, did you have any comments on using N95 for specific cases or surgical masks for others, or N95s for all of them? How is Mass General handling?
Yeah, sorry, I just heard. Yeah, someone's phone's going off, and so it's yeah. So the N95 is obviously a controversial topic. So what we're reserving N95s for essentially strict isolation or aerosolizing procedures, essentially during transesophageal echoes. For droplet precautions, the recommendations are a surgical mask with some kind of eye protection, either a face shield or goggles. So it's all related to resources and risk. You know, ideally, sure, N95s for everybody, but frankly, we don't have those resources. So we're reserving the N95s for higher risk aerosolizing procedures, and then the surgical mask and goggles for non-aerosolizing procedures.
Yeah, thank you, Judy. I want to just take on this question, which is how do you deal with ECG stickers, leads, and other sort of items here? And Dr. Taub, do you want to answer how you deal with this at Montefiore? Cynthia, are you on? All right. What I will say is that one of the things we got on our Q&A was that some folks are dealing with this without ECG stickers and leads, and they're going straight with just the timing issue and not bothering with the EKG at all. And some of them are using syringes, to put gel on and then just let it go, as opposed to using a reusable bottle. So that's something. Judy or Jim, do you have any comments on how to deal with some of these items like ECG stickers and leads?
Yeah, I can comment on that. We're still using ECG stickers on our for our studies, even with focus studies. And in terms of gel, we're for the COVID positive or highly suspected COVID, we're using disposable gel packs as opposed to bringing the whole bottle in. So that's our practice at our institution.
Yeah, we've had the disposable gel packs. That's our standard procedure anyway. I think as far as the ECG leads, it really depends. If you need something that has to be timed, then you should probably use them. But otherwise, most of the time, at least in our institution, we can get away with just setting it on seconds.
Got it. Thank you. Now we move on to another set of questions. Again, a lot of questions on N95 masks, and Cynthia had commented on cleaning the N95 masks, assuming we don't have it right now. What about the cleaning of the N95 masks? Actually, Judy mentioned this as well. I know from our experience at Duke that we do have a re-sterilization process for N95 masks. But then the other issue is that does your hospital, and Lanqi touched on this just in a little bit, that there's an advisory for using a surgical mask on top of an N95 and then discarding that perhaps, before going on to the next study. But let's say if you did use an N95 mask on a COVID positive patient, are you supposed to send it for cleaning or reuse, or do you discard it before going on to the next patient? How is that handled? If Cynthia is not on, Smadar, would you want to take this on, please?
Sure. So we do use N95 for suspected or confirmed cases of COVID. We do not use it for patients that we do not suspect COVID in, which is very few patients these days. When we do use the N95, we do cover it with a surgical mask. So the N95 can be reused afterwards. And the current recommendation is to put those masks in a brown bag and leave it open so it can air dry. You don't want to leave it in a closed plastic bag. Ideally, if you have 4 of them, you can alternate between them and just put the date on your bag so you know which one you used. If you don't have 4, then you just use it. And I've heard different data. Some people said that you can wear it to up to 100 hours, but you should always check the outside of the mask and make sure that it's not soiled, there's no droplets of anything on it, in which case it really should be discarded. Or like I mentioned before, if you can sterilize it, as we do at Stony Brook, we do work with an outside company that does the process for us. So even if the mask was exposed to aerosols, we can now reuse it again after it goes through this process. So you really have to think outside the box and come up with ideas as to how to rethink those, how to reuse this really limited supply that we have at this point.
Thank you so much, Smadar. Now for the next one, I'd like Carol Mitchell to give her opinion on how do we minimize exposure time, and from Carol, then we'll go to Smadar again. But Carol, would you like to take this one? How do we minimize exposure time for exams?
Sure. So I think for sonographers in particular, it's important to be real aware of communication. First, you would want to talk with your medical team, determine, can you do an abbreviated protocol? Do you have a COVID protocol at your institution you're going to implement? And what is the clinical question, to make sure that if you do need additional views or you do need to tailor the exam, that can be done. You also can make determinations then, can this be done with a point of care ultrasound system, or does it require a full cart and more of a comprehensive echo, depending on what you need, such as if you needed to do strain. All of the measurements should be made offline, as we've talked about previously. And then some other special considerations, I think, for sonographers are if you can use a handheld device. Again, depending what the clinical question is everybody familiar with how to use that device? Because the key is really limiting exposure, and that's limiting the number of personnel that have to be involved in doing the exam, and also limiting the time of the exam. So if this can be done with a handheld, it's going to be easier to maneuver with that type of a system. But the other consideration is that everybody needs to know the knobology or the instrumentation on whatever system they're going to be using, because that's going to make the exam go faster. If you go in to do an exam with even a handheld device or something that you're not familiar with, you may actually be extending exposure. The other thing is, can you call and talk to a nurse ahead of time if you're doing a portable? That could they help, or if they're going to be in the room working with the patient, facilitate getting a setup where you can get your system in easily. So if you need to scan on the right-hand side of the bed or the left-hand side of the bed, is that going to be available to you? And then I think with that information, if you find out that, you know, just on where the vent is or other things, you may have to scan right-handed. And then do you have somebody in your department who's very familiar with right-handed scanning or can do it just as fast as left-handed, so that they are, again, not delaying time by trying to scan right-handed when they're not as comfortable. So those are just some things to think about. And then I'll defer to Smadar, Dr. Kort, to talk a little more on some of the protocol changes that they're doing.
Carol, you can always call me Smadar. So what we've done at Stony Brook is that we implemented focus scanning protocols, which are indication driven, before the sonographer goes to the bedside to scan, and all of our studies are now portable. We don't bring any patient to the lab. So we go over the history of the patient, what is already known from prior studies, the indication, and therefore the sonographer really has a plan as to which views to use and how they can quickly just answer the question that was asked. We don't connect patients to ECG leads to save time on connecting, disconnecting, as well as disinfecting the leads. All the measurements and calculations, like Carol said, are done offline in the echo lab, not even at the bedside or outside the room. If the indication is to assess LV function or segmental wall motion abnormalities, a nurse goes with a sonographer and is readily available to inject contrast if need to. So the sonographer does not have to wait for a nurse and contrast to show up. We also don't use novice scanners. We don't use students. Everyone that scans a COVID patient is experienced with scanning, is also very comfortable with the machine that they're going to use. For procedures that require consent, like a TEE, we now communicate with patients via an iPad, so both the history as well as the consent can be obtained remotely, not while someone is in the room. And I do want to emphasize that the goal is really to scan quickly, but also not to compromise quality. Also, if the sonographer sees any abnormality that has not been known before, even if it's not part of that focused exam, they would still get those additional images. The goal is really not to repeat any studies unnecessarily.
Great, thank you so much. We have limited time, so I'm going to keep going with this. We've answered some of these questions, especially with regard to optimal ergonomics, and we've also talked about best barriers to use to protect sonographers, and some of these ideas are posted on our COVID resource page that members have shared on how to do it. So I would encourage any one of the attendees on this webinar to go to that website and look at some of the resources shared. Also in our Connect at ASC forum, several people have shared their best practices for protecting sonographers, and Carol did hit on this optimal ergonomics as well. I'd like to move on to a couple of things about scheduling cases. And one of the questions that came up last time several times was, how do we handle TEE before elective cardioversion? And I'd like to pose that question to Judy, please.
We've essentially deferred TEs for elective cardioversions. I mean, if they're, if they're otherwise stable, we're deferring those. We are still doing TEs on patients who are in acute heart failure due to, atrial fibrillation for that, but that essentially we've deferred them.
Great. The other question that came through was, have appropriate use criteria for TTE changed now? And Smadar, do you want to answer that question?
Sure. So AUC have not really changed. We should always consult with AUC recommendations and perform mainly appropriate studies while using our clinical judgment. The goal now is not to just perform appropriate studies, but really perform only those that the information obtained from the echo will change the management. Patients may still benefit from having those echo, but it can be done at a later point. For example, it would make sense to wait until the COVID status of the patient is known, since if they're ruled out, we can save on unnecessary use of expensive PPE. For non-COVID patients who could otherwise be discharged, we may recommend an outpatient echo immediately post-discharge so we can turn the hospital bed quicker. And finally, all the recent AUC documents for the use of imaging are addressing multimodality, not single modality. So it is also important to know what other potentially less hazardous options are available for us. For example, in some places, including us, we started to use now CT to exclude left atrial appendage clot instead of using a TE. So you need to be familiar with what is available for you and utilize that.
Thank you so much, Smadar. Jim, how far out are you scheduling elective echo exams? Seemingly now that Seattle has hopefully seen the worst of it, how far are you scheduling these elective ones?
That's a great question. When we first went through our lists, and this was several weeks ago, to try to extend them out and do that, we were figuring it at about a month. Well, our governor has now extended the stay-at-home order until May, and so we certainly aren't going to be scheduling anything before then. Unfortunately, this puts a lot of stress on our schedulers because they have to change constantly depending on what the current situation is. But what I would say to everyone is that whenever your stay-at-home order expires, that should be the minimum timeout that you're thinking about doing this. Now, the other problem is, of course, that everybody's different and every echo exam is different. And some of these exams, although they could wait a month, maybe can't wait 2 months. And so we do actually have to consider that. And we have actually taken to having our fellows actually go through all of the echo exam orders and try to figure out whether they should be done and when they should be done. There is some communication that is necessary with the ordering clinicians as well. Fortunately, our fellows are at the moment being sort of platooned or kept in reserve in order to be used when the time comes for a surge. So about half of them are at home right now, and we're trying to find ways to continue to educate them, continue to involve them in the process. And this is one of the things that we're having them do. In some cases, attending physicians who are less busy because we have deferred these elective studies are doing it as well. But I think that there's very important aspects here in this. We have to remember that people still get cardiovascular disease. I fear that there will be an uptick in non-COVID cardiovascular disease when we're all done with this. And we have to remember that echo is still the cornerstone of diagnosis in many of these cases. We cannot defer and call elective things out in perpetuity. We have to actually be careful and do this very thoughtfully.
Yeah, you're absolutely right. As one of our senior physicians said, that you can defer the case, you cannot defer the disease. And so we certainly will likely see an uptake. But if Cynthia's on, I'd like her to address this question in this series, which is, should echo be limited? What is your threshold for doing an echo? Is it limited only to people with patients with evidence of cardiac involvement, such as elevated BNP or troponin? And if Cynthia is not on,
I am on.
Oh, you are. Okay, good. Can you take this question on about your threshold for doing an echo? Is it elevated in these times?
So just to follow up what Jim just said, the disease is cardiovascular disease is still there. If we're just focusing on patients who come in with COVID and with positive troponins, we're going to miss a big cohort of echoes that we should have been performing. So it's certainly case by case. You have to evaluate the situation and see if this is a repeat request or this is a fresh request. We were utilizing our nursing staff. The stress nurse was performing our screening process, communicating closely with the team, but now she's been pulled to cover critical care, CCU, so we're utilizing our fellows, our attendings are actively involved in screening patients and determining whether we should be performing an echo. Certainly we're seeing, about 20% of our COVID patients who are in the intensive care unit are having cardiac involvement. And it's extremely exciting that we're learning new things. And, the question about whether we should be doing extensive studies, the answer is absolutely not. We need to protect our staff. We're doing focused echo. We have COVID-specific abbreviated protocols to look at LV and RV systolic function. A lot of these patients have RV dysfunction, and LV systolic dysfunction can be global, can be regional, and don't forget that we still have coronary disease, acute STEMI, and those EKGs can be indistinguishable sometimes. So this is our Madhav, your experience, and in terms of manpower, the echo lab in general is somewhat underemployed. We have to think innovatively and make sure that we fully utilize our talent to do what they can do to help us.
Great, thank you so much. And given these questions that have come up regarding scheduling, one of the things that came up interestingly was, how do you handle stress test requests on first responders, such as policemen and firemen and people like that? Do any of you have experience with that? Cynthia in New York, especially?
You're asking about stress testing in this situation?
In first responders specifically, that was the question that came up.
Oh, sorry, I missed your question. So can you repeat the question again?
Yeah, how do you handle stress echo requests for first responders?
Okay. Well, the whole situation is quite stressful. We're experiencing stress testing on a daily basis, but we've in general stopped our stress testing. We think that any stress testing should be considered elective, and we need to use other modalities to assess these patients.
Okay, great. We are rapidly running out of time, but I want to get to some of these questions. And I want to start with posing this to Smadar as to, can you summarize what is specifically we should be looking for on an echo exam in COVID patients?
So we know that many patients with COVID do have myocardial involvement, pericardial involvement. So we have seen some cases with myocarditis. And just like any other viral myocarditis, you should look for evidence of either global wall motion, globally reduced systolic function, segmental wall motion abnormalities. Very important to look at the right side. We've seen many cases with PEs in our institution in the setting of COVID. So we typically look at the right side. We calculate the PE pressures. We look at the TR in those patients. We look for pericardial effusion. Many patients can have myopericarditis and they can have some pericardial effusion. I've seen some reports of tamponade physiology in those patients. So if the sonographer does see pericardial effusion, they typically look for tamponade physiology as well. Those are really the big ones, really assessing LV function, systolic function, some diastolic function as well. Looking for wall motion abnormalities. The right side is really important. You can see some valvular disease as well, especially if the left ventricle is dilated. You can see acute MR, you can definitely see TR. So again, if we see those, we expand the protocol a little bit more and scan and visualize those abnormalities.
Thank you, Smadar. And I just wanted to stress that we had talked about this a few days ago as well. The question of value of strain imaging had come up, and we had recommended that all these assessments be done offline, and then the goal is to limit the exam to the most essential information, especially in light of making decisions, clinical decisions, things that will impact clinical decision making. Lanqi and Carlene, can you take this question about staffing, and then especially this one about what are your institutions doing to protect staff who are pregnant?
All right, thank you so much. Certainly, pregnancy topic is very hot in our hospital as well. We do actually consider pregnant individual employees is in a high risk to COVID infections. So in general, that if we can avoid them to be in there, and we avoid them to be in there. However, if the pregnant employees, if have the appropriate protections, it's still safe to go in to do the COVID case. If that's the choice, that's the only choice you can have. So it's still safe if you have appropriate protections. But otherwise, you can, recommendation is that if especially you have like after more than 37 weeks pregnancy, you try to avoid that, because this is really a recognized virus, a new disease, and really we do not know how this will affect fetos. So this is our institution policies. So in terms of other staffing that we are, I'm going to answer that how do I do with our staff. So in the other situation in our lab is that I'm trying to remove the older, just like AESC recommended, have some medical conditions such as diabetes, asthma, heart disease. We try to move them to outside work, some at home, not try to avoid to come to work here. And also since we have a lot of we cancel a lot of elective cases, we have very light outpatients patients. So we actually schedule half of our staff work at home. We alternate them to two different groups, A and B. We try to, the two groups is not going to cross each other, so we avoid that, work together at the same time too. So we basically divide the group to half to A group, half to B group, so they alternate to come to work. That's another way to minimize the exposure. So that's about what we do.
Okay, thank you so much. We're rapidly running out of time, so I want to just ask a couple of more questions on this. Jim, how are staff being tested? Are staff being tested if performing exams on COVID positive patients? Do you have any policy on that in Seattle?
No, we are not doing that. And there is certainly a theoretical advantage to making sure both that staff are actually not transmitting between different people, and then sort of seeing if they actually get infected and have an asymptomatic infection. What our official policy has been is that if people are showing signs of illness, they need to stay home. And that's incredibly important even for non-COVID infections, because obviously that clouds the picture, and we really don't want to super infect anyone with separate infections, although it's not known exactly, to my knowledge, how COVID interacts with other infections other than probably bacterial pneumonia. But we don't actually test staff frequently. We do have a rapid test that comes back very quickly, but I know that this is not available anywhere. You of course have to take into consideration the time lag from the time the test is administered to when you actually get the results.
Right. So I want to wrap this up fairly quickly. There's some other questions that have come up, and a lot of these questions have been addressed in our statement that we have, including the handling of trainees and students and fellows. And it's important to go through some of those because a lot of your questions have been answered. A few supplements will be coming up shortly, including one on pediatrics and one on intraoperative echo and one on point-of-care ultrasound. That will be coming up shortly. That will be published within the next few days, followed by webinars as well. So I would encourage you to attend those and ask your questions again. Some of these questions that we've had that we could not get through this time, we're going to collect them and post them on our website under an FAQ section. So please be on the lookout for those. I want to thank all the panelists for their support and for participating in this wonderful webinar. We'll have this webinar recorded and available through our YouTube channel and communicated to all our participants and by email to all our members as well. I want to thank our sponsors as well, who have graciously underwritten this webinar. And so thank you to GE, Hitachi, and Philips as well. And we would encourage you, if you're not a member of ASE, to join the American Society of Echocardiography and also go to the COVID-19 resource page, where there are lots of there's lots of good information available. So thank you to all our panelists, and thank you to our staff, Christina LaFuria and Liz Lane, for their wonderful work behind the scenes. Thank you so much.